Hello, welcome back. Another episode about determination of goals of care. Um, in my most recent interviews with applicants, I have been talking about the importance of knowing the American healthcare system, and with that comes determination of goals of care for the patient. Very sensitive topic and very important for attendings when evaluating residents or interns, because it's usually the interns the one that has to have this conversation, because it deals with your ability to make a connection with the patient, with their families, explaining not only their condition, their prognosis, and what can we do or what can not we do or what shouldn't we be doing, uh, which are the alternatives of treatment available, and within those, carefully explaining the DNR, DNI, and comfort care alternatives. So, why I think this is important for you? Why I think this? I talk so much about this when we talk during interview preps about this. Is because um, it helps a lot when a patient is admitted to know these things, and the flow of the care has to be directed to what a patient wants out of their inpatient stay, knowing their goals. It deals with autonomy, patient's autonomy. Um, you know, does they really want to be here because they want to be completely cured, or does they just want to be here because they just want to be comfortable with their disease and not experiencing severe symptoms? Okay, so let's start with a case, so you can try to put yourself on this situation, and I find this very often in the inpatient care setting. A patient comes, patient is, let's say, 90 years old, advanced dementia, to the point that the patient is non-verbal anymore, and to the point that the patient is bedbound, cachectic looking with contractions, and she has a G tube where the family feeds her, and the patient is coming for aspiration pneumonia, very often in patients that are bedbound with dementia. So presents with sepsis initially, and we say, okay, this patient is coming with severe sepsis due to aspiration pneumonia, likely from her current condition, her underlying current condition. And while trying to put together your HMP, then you come to the part that's called the code status determination. Because the HMP that we know, as we know in from medical school, has a different part now that you're in practice, and that's called determination of code status. And that determination of code status means, is this patient full code, where you're going to be doing everything possible in case their heart stops, meaning resuscitation, or if they stop breathing, or they need they are unable to protect their airways, are you going to do intubation and mechanical ventilation? Or is this patient a DNR-DNI, meaning keep doing what you're doing, but in case their heart stops working, or you see that they're hard to breathe and they need to be intubated, don't do it. Let them go. So determination of that part deals with the code status part. And on your history taking, depending if the patient is able to talk and you think is able to make sound decisions, then you can get this answer from the patient. You can also get it from an existing advanced directive, or you can get it by talking to the next of kin or the assigned appointed DPOA, power of attorney. Yeah. So such a hard conversation, and this is the part that you will be evaluated on. Sometimes even your attending will be there when you try to start this conversation, and yes, practice, because it is a step-by-step process. You just don't go and say, hey, what's your code status, or what's your mom code status. You have to explain why are you asking this sensitive question. And the way I do it is, let's say for this patient, right, I explain you that how advanced her condition is. So the way I approach this is, I go to the next of kin or the power of attorney person, uh, and I started saying, hey, my name is Dr. Munoz. I'm the attending physician during this hospitalization, and I'm taking care of your mother. We found that she has sepsis due to possible aspiration pneumonia, which is something that we commonly see on advanced dementia patients that are bedbound, regardless of having or not a G-tube. So her condition is very advanced. She is on a point of sepsis, and at this point that we found that this is possibly related to pneumonia, we're going to give her antibiotics to treat the pneumonia. We're going to give her fluids to treat her dehydration. We're going to wait to see how she does. Now, the thing is that, as you know, your mother is of advanced age. She is of poor functional status, and she is not alert, she's not awake. I want to ask you, if, let's say, something happens later on at night, what are your thoughts on what can we do here? And why I'm asking this question is because in the hospital, when we have a patient in this hospital or in any hospital, we need to know what are the goals of care for this patient, so we don't get to do something that we shouldn't be doing based on those goals of care. So, we're doing everything possible to treat her with antibiotics and to hopefully to get her back to her baseline, but sometimes it doesn't work like that. Let's say tonight she's doing fine, but let's say at midnight her heart stops completely. It doesn't beat at all. In that situation, we can resuscitate her. We can do CPR and even electric shocks if that's what you want. That's called resuscitative measures. Or we cannot do it and say, okay, let her go. Don't try to bring her back with resuscitation. What do you think will be what your mother will want if this situation will happen? And the answer is a hard question. It's a hard question. The family members usually think a little bit about that. Some of them have it clear. Some of them say, don't bring her back. Let her go. If that's the case, let her go. I think she lived long enough. I think she doesn't have a quality of life anymore, and it will be better to not have her suffering. If this is her time, let her go. Some of them say, bring my mom back, resuscitate that heart, and intubate her to control all the settings and try to fight till the end. Two different pathways, right? But it's their decision, and that is what you should do. You should respect their decision and find out what they want, even if sometimes it seems inappropriate or it seems futile to do all these things for a patient that's very advanced. We have to start by respecting their wishes. Later on, if the condition continues to worsen and they still think the code status should be full code, then you can readdress this. But the initial assessment, the initial the initial conversation is towards finding out what they have in mind and understanding why they have that in mind. Sometimes they say, yes, I talked to my dad before when he was coherent with it. I talked to him about this and he said, yes, keep me alive. Or some of them said, no, by no means, don't even try. So you will find different patients that think they have different perspectives about this, but that's the point. Finding out what they want. Okay, why is this important? This changes the flow of the hospitalization so much. If you find out this early on the hospitalization process, you can say, okay, so this patient is DNR-DNI and has pneumonia. So this patient can be seen in a telemetry unit, and our approach is less invasive than the other patients. And in case she crashes, we're not going to transfer her to ICU. We're going to try to do our best in telemetry. What I wanted to say about this is also that for these are two different situations, right? But there's a third situation that is the comfort care status. Let's say the same patient in the middle of the night, let's say it's 10 p.m., and her oxygen saturation goes low to 60%, and her heart rate is on the 50s, and she seems to have an agonal breathing. She seems to be breathing and labored, and she seems very uncomfortable. She's moaning here and there, and she seems in pain. And by this time, you already know that she is DNR-DNI. Then you cannot just say, okay, so she's DNR-DNI and we're gonna just let her go, because as I described, she's suffering right now. It seems like she's actively dying, but she is suffering. She is having this labor breathing. She's having this apparently she's in pain because she's moaning. She's not comfortable. Yes, it may be happening that she's passing, but she's doing this uncomfortably. So what can we do at that time? We know she's DNR-DNI, but we have to do something. And that something could be the comfort care measures. So you call the family and say, hey ma'am, hi, it's Dr. Munoz again, and I'm calling you because there's a sudden change on your mother's condition. She suddenly started presenting more symptoms of shortness of breath. She seems very uncomfortable. She seems in pain. Her heart rate is very low. Her oxygen levels in her blood are very low. I believe she's actively dying. I think this is her time, and she's decompensating right now. So the reason I'm calling is because we believe she's suffering, and this suffering is uncomfortable. At this point that I believe she's actively dying, I can help with comfort measures, therapies. And one of the ones that we like to use include a morphine drip. And what this morphine drip does, it relaxes the lung musculature. It relaxes this apparent sensation of shortness of breath. It comes with sedation that comes with morphine, and it may come with respiratory arrest sometimes, but that's not the intention of this therapy. The intention of this therapy is to palliate the symptom, is to make her comfortable, because I believe she's passing. I just want her to, if she's doing that, I want her to pass comfortably. So yes, I believe she's passing, and the way I can help is by by providing relief to her symptoms. Would you agree for me to stop everything I'm doing, to stop the antibiotics, to stop the vasopressor support, to stop the blood work testing, and focus on her comfort to allow her to pass? And she say, if she's on board with all what's going on, she could say, yes, doctor, start your orders for comfort, and we'll see how she does. So then you start your orders for comfort care, call hospice, inpatient hospice, transfer her to the hospice rooms in your hospital, and most of the time these patients on these orders on inpatient hospice, they pass within that hospital stay. Some of them make it to be hospice at home, hospice at a facility, but then that's a sudden change from what initially was a patient that came with sepsis, DNR-DNI, and now it's comfort care. It can happen. Or sometimes they can just go home after improving. You don't know, right? But you have to be prepared. So that's one. Those are the three scenarios for goals of care: the determination of status, code status, and keeping in mind that you can also provide comfort care. It's very important to find out this from the beginning, because you save time to everyone. You, most important, find out and respect what a patient wants from the very beginning, because not every patient wants the same. Some patients know they have advanced stage 4 lung cancer, and they're coming because they are vomiting super hard after chemotherapy, which is at this point palliative, and they just want for you to hydrate them and send them out. Or some of them don't even know that hospice care is an alternative for them. Sometimes patients are so tired of chemotherapy and radiation, and then they get to this point that they come hospitalized, and you said, sir, it seems like you're very tired, it seems like you want to be at home, and you don't want chemotherapy anymore. I wonder if what you want is something that aligns to the philosophy of hospice care. You may be surprised of what you find when looking into this. So that's my experience with determination of code status and finding out the goals of care. Try to bring this up somehow during your interviews, because it's very important for a program director, any preceptor on the inpatient care part of residency, to know that you're able to do that, to know that you are able to have that conversation and carefully discuss such sensitive topic. This where you learn the most about this is on the palliative care rotation. The palliative care rotation has to do with palliative care medicine and hospice care, pain management. It's a very, very holistic patient-centered approach where you have many. It's a team. You have usually a palliative care doctor. You have a social worker. You have a chaplain, a case manager that provide resources to the family and patients so they understand what you're gearing towards. Maybe with hospice care or with palliative care therapy outside the hospital. And sometimes when you start researching your programs, you will find that the program director at your interviewing hospital is a palliative care medicine, or a geriatrician, or a pain management specialist. They are very interested on this part of medicine, of the finding out patients' wishes, goals of care. So you may impress them by knowing this little thing about the HMP part that is so sensitive. Okay, so that was my little session on palliative care and goals of care. Hopefully, you get some of these. Watch this video again. See if there's something else that you could read um, on the internet, or ask patients if you're able to schedule a rotation in United States to to gain your clinical experience. Maybe try to do one on palliative care medicine or pain management at a cancer hospital, and you will get tons of experience with this conversation, tons of first-hand experience on how they deal with this. Well, thank you very much.